real pleasure to be here this morning with my colleagues here at Cedas Sinai Medical Center in Los Angeles. We're the largest hospital in Los Angeles, and we've had over 600 COVID patients in our hospital and about 200 in our ICU. And what we'd like to do in the next 30 minutes is share with you our experience. I'm thrilled to have three of my esteemed colleagues with me today. Dr. Peter Chen, who's the director of our Division of Pulmonary and Critical Care Medicine. Dr. Chen is an expert in acute lung injury, both from a clinical management side as well as running an NIH-funded laboratory. Dr. Vic Tapson, who's a national, international leader in pulmonary hypertension and thromboembolic disease, is going to share his experiences with the COVID trials. And Dr. Jonathan Grein, who is our director of clinical epidemiology, infectious disease expert, who's been on the cutting edge of the antivirals. So I think what we'll go ahead then and get started and first talk about our experience in the ICU. Our first intubated patient was March 10th here at Cedas Sinai, and it seems like an eternity ago. So I'll ask Dr. Chen to sort of outline for us what our experience has been and how it's been evolving over this 4-month period. Dr. Chen?
Thanks, Dr. Noble. We learned a lot actually over the last 3 months about how to care for these patients, these COVID patients. And when it first started, I leaned heavily on some of my friends in the community, particularly Laura Evans at University of Washington. They were one of the first epicenters in the United States. And what we saw very quickly was that, initially we were seeing that they were primarily just single organ failure. Now that's kind of changed since then, but our early experience was that this was primarily a respiratory failure caused by the virus. And we would see that the patients would have increasing oxygen needs, ultimately get on high flow. And what we decided early on was to use high flow at our institution and not use non-invasive positive pressure ventilation, such as BiPAP. And we would bring them to ICU and watch them on high flow nasal cannula. And in general, you would see that their oxygenation would go up over the next 24 to 48 hours when they got to that point. And this usually would happen about 7 to 10 days into their clinical course. If they got so bad that we needed to intubate them, we would proceed to intubation and mechanical ventilation. And in general, we would try to do that pretty early on in the course and not wait too long and try to hold them off from intubation. And that was largely because the intubation process, we would have an airway team come, and they would have to take proper PPE precautions in order to get prepared for the intubation, and it was quite a process. And so we didn't want to have any emergent intubations. And the process that we set up with bringing patients into the ICU a little bit earlier when they're on high flow has really worked out really nicely, because we really haven't had any emergent intubations on the floor for the most part. Once they got intubated, we would treat them just like any other ARDS patient, and we'll go into that discussion a little bit later on. But what we have found is that their lung injury would be very prolonged, and their ARDS would last for, it felt like weeks sometimes. But really what was happening was that their ARDS was being managed, but then they would start getting other complications along the way. And we'll be discussing a little bit of the complications with coagulopathy and such. But now we're seeing that they have other issues such as renal failure, a lot of clotting. There has been discussion about cardiomyopathies. We actually haven't seen much of that, but it doesn't mean that we have not seen it. And then ultimately, as we care for these patients and their lung injury improves, we get to the stage of trying to wean them from the vent. And that has been quite a process, because we have found that they have a lot of delirium afterwards, and managing them after their lungs have improved has been very difficult also. And so we're finding that we're doing tracheostomies now and having to try different types of sedation in order to manage them so that we can start weaning them from the ventilator while managing their delirium. And this is not unique to us. I've talked to some people in the community, and it seems like that is a common theme that we're seeing in patients with COVID ARDS. And talking to someone at Johns Hopkins the other day, they actually said that they looked at the sedation for these patients, and they're actually requiring a lot more sedation in COVID patients than in control patients such as influenza and other diseases. So then once we get them off the ventilator, then it's, they have a very long recovery course.
Yeah, one of the things that struck me in the first few weeks was that these patients would have profound hypoxemia, yet some of them would be sitting there, even if they were intubated, they'd be on their computer or their phone. And their compliance really seemed to be substantially better than what we typically would see with a classic influenza ARDS patient. I think that's evolved over time, but it's one of the nuances I think that we noticed early on in the process. I think that we're seeing some changes in the nature of the virus itself over this sort of 4-month period of time. But maybe we could move on a little bit to the next topic, which is to talk a little bit about the potential progression of the COVID effects on the lungs. I know we've seen some CAT scans where we've seen destructive lungs, which is not, again, typical for ARDS. But Peter, could you make a couple of comments on that? And then we'll move on to our other colleagues as well.
So you're right. For the most part, people with ARDS, if you look at studies, their lungs tend to return to normal over time. They might have some scarring here and there, but overall lung function will return to normal in large population studies. For the management of these patients, we are treating them for the most part just like ARDS in many ways. But as you already spoke to, we find the lungs are very compliant. There obviously are the ones that have less compliant lungs, but because they're so compliant, we can use a lot of PEEP in them. They tend to be PEEP responsive. And then one of the other things that we heard early on, anecdotally through the community when we started seeing patients, was the use of proning ventilation. And so proning does tend to work for them. Proning is a problem because it is quite a process and it can cause lots of ulcerations on the face and so forth, but it does tend to help the patients. And so we use our typical P/F ratio of 150 as a cutoff for proning ventilation, and we've gone to early proning for these patients.
Great. So maybe we could transition a little bit to the coagulopathy that we've been seeing in these patients. One of the things I think that struck us was we'd see clotting in the, in the CRRT trying to dialyze patients. We saw a lot more thromboembolic disease, it appeared, although it was difficult to do CT angiograms in the first month. But maybe Dr. Tapson, you could comment a little bit on what your sense of the coagulopathy has been and how this may be different than what we see in respiratory failure from other etiologies.
Sure, Paul, thank you. Well, certainly we wondered at first if this coagulation problem wasn't just that we're seeing a lot more critically ill patients. It was argued about initially, but I think, just like you suggested, I think this is a prothrombotic disease. And we learned, as you noted, Paul, dialysis catheters, CRT catheters. I had several nurses tell me from some of our research trials that the blood's difficult to draw. I try to draw it and it seems to coagulate. I mean, all these little features. One of the big questions is it macroscopic thrombosis or microscopic? And I think it's both. I think we are seeing more DVT and PE. And the early Wuhan data suggested that in these patients, we're seeing a DIC type picture, very high D-dimer levels, but interestingly, kind of mild thrombocytopenia, elevated biomarkers. And so when you get infection from various agents, you get this systemic inflammatory response as part of innate immunity. And based on that, you get activation of anticoagulation. And some people are calling this thromboinflammation or immunothrombosis, but it seems to be tied to inflammation. These patients are have this cytokine storm, if you will. There are a number of reasons why I think we get this coagulation problem, and it involves inflammation. So we monitor these markers. We've seen, again, from the early China data, very high D-dimer levels correlate with mortality. So we see DVT, we see PE, and a fascinating entity that has been reviewed and published were some data looking at patients with the flu and then patients with COVID and comparing their autopsied lungs. And it's fascinating information. In ARDS and the flu, you see perivascular T-cell infiltration like you might not be surprised to see. In COVID, there seems to be these really distinct vascular features. You get severe endothelial injury, and this is associated with intracellular virus that can be seen, disrupted cell membranes, histologic analysis of these vessels. clearly abnormal, widespread thrombosis, thromboangiopathy, if you will. And in these COVID patients, in the study, one study published not long ago in the New England Journal, these autopsy reviews showed that there were approximately 10 times the amount of microscopic thrombosis with microangiopathy in these COVID patients than in flu patients. So I think it's different. It's not just critically ill people getting DVT-PE. It's that, but it's also probably a microscopic thrombosis picture, which might explain some of these patients that have sort of unimpressive infiltrates, but big sort of shunt physiology. They're very hypoxemic, and you look at their x-rays and you just don't know why. And of course, in those patients, we look for PE, and sometimes we don't find it. So it's
fascinating. And I thought maybe it really is remarkable. And thank you for those comments. I'd like to turn now to Dr. Jonathan Grein. While it seems like an eternity since we've been taking care of these patients, what has really struck me is the treatment algorithm that we were using back on March the 15th, Dr. Grein. I'm not sure that we're doing any of that at this time. I wonder if you could give us your perspective about how our treatment has evolved and what we are currently focusing on right now, and then we'll transition into the clinical trials.
Yeah, happy to, and thanks for having me. I mean, one of the fascinating things about this pandemic is how quickly our understanding of potential therapeutics has changed just over the last few months. As you mentioned, it's really amazing how quickly we've had to pivot and think about how to treat this disease. And so obviously there's a wide range of potential therapeutics that are being looked at. And I know at our center, we're currently evaluating several as well. But the one class of agents looked at first were these antiviral agents, and remdesivir was one of the very first antiviral agents that we looked at. We were one of the first hospitals in the country to evaluate it. And I'll just say, the nice things about remdesivir is it's a direct acting antiviral. There has been some experience with this prior to COVID. It seems to be well tolerated. The side effect profile is fairly modest, obviously LFT abnormalities and such. But now we're finally getting this data coming out, at least preliminarily through the ACT trial. And thank you to Dr. Tapson for being the lead for that here. That shows that there can be clinical benefit. But the caveat with remdesivir treatment, and it really applies, I think, to all of these treatments, is understanding the optimal time and patient group to use them in. And I don't think we're going to find one single treatment that's going to be the silver bullet for all of this. But with remdesivir specifically, it seems that the benefit is mostly in patients that are on some supplemental oxygen, but have not yet progressed to that to the point where they require mechanical ventilation. If you can get to that group of patients early and give them an antiviral agent kind of before that progression, that's probably where the largest benefit is. I think it seems like every day additional information is coming out. We'll see what comes of the dexamethasone story, for example, and convalescent plasma and others, but it's really been fascinating to see how quickly this is evolving.
I think that's right. And when we were initially treating these patients, a lot of them were receiving hydroxychloroquine and azithromycin, and we've really moved away from that as data have emerged. And certainly in my career, I've never seen clinical trials develop this quickly in an ICU setting. And I wonder if we could transition maybe back to Dr. Chen and to Dr. Tapson about the clinical trials that we're involved with here at Cedars, comments perhaps on others going on nationally, and where we think our focus needs to be.
So, I think from a clinical trial standpoint, they're really kind of falling into big categories. You have your antivirals, you have the anti-inflammatory, and then now we're really starting to see a lot of trials come on for coagulation and thrombosis. So, from the antiviral standpoint, I think Jonathan really hit the nail on the head is timing. And by the time these patients get in the hospital, their viral load is probably on the decline in many ways. And remdesivir is an inpatient therapy. And so the benefit for them may not be as effective at a later stage in time. And I think that's why you're seeing when they get to ICU level and so forth, you might not have as much of an effect from the antivirals. And so moving the antivirals earlier on in therapy probably, or in the clinical course, would probably be more effective. And there is a lot of research going on into outpatient type of antivirals. You hear about a lot of different repurposing of different antiviral medicines right now. But one in particular that we've been working on here is a drug by a company that developed an antibody towards the virus. And the way they identified it was that they took one of the first patients that survived from COVID in the United States, and they purified from the blood and the plasma all the antibodies that bound the virus, and they were able to isolate the antibodies that bound the spike protein the best. And the spike protein is what the virus uses to bind the ACE2 receptor to enter the cell. And by doing that, they can prevent the virus from entering and decrease replication of the virus. And there's actually been a lot of studies coming out now independently of this company that has demonstrated its effect in actually reducing viral load in animal models and reducing lung injury. And so, we started the phase 1 with Eli Lilly in-house, and that was amazing because we started that end of May, and then we started the phase 2 almost 2 weeks later. And kind of what you're saying, Paul, we have never seen anything happen this fast before. And it's been quite a whirlwind. And the phase 2 actually is moving to the outpatient setting and really trying to treat these patients early on in their disease course. And that really might be where we have some effect with these antivirals. And hopefully it would be the difference between someone feeling kind of cruddy and staying at home versus coming to the hospital getting really bad ARDS. And then as far as other trials that are going on, we do have some anti-inflammatory trials going on here at Cedars, and I think Vic can speak to some of that. I'll turn that over to Vic.
Oh, thank you, Peter. Well, sure. So as Jonathan nicely mentioned, remdesivir has been a big focus here at Cedars. Jonathan published some of the early data in New England Journal, which is really nice. And then both of us worked on this Act 1 study looking at remdesivir versus placebo. And just in a nutshell, it was really exciting to be involved in an NIH study where we enrolled 1,000 patients around the world in a matter of a month or so. And briefly, we enrolled about 1,000 patients and about 25 here at Cedars. These patients got remdesivir placebo, and as was discussed earlier, patients improved their recovery time if they got remdesivir from 15 days without remdesivir placebo to 11 days. So faster recovery time. It looked like a signal with mortality, but it was a big study, encompassed a lot of different kinds of patients. But if you required supplemental oxygen, it looked like you improved. High flow oxygen looked like you improved. The sicker patients, like Jonathan mentioned, maybe not. We've moved on now with those results to the Act 2 trial. We're in the middle of it now. We've enrolled half the Act 2 trial already, which is remdesivir in all patients based on initial results versus with baricitinib compared with placebo. So placebo arm, baricitinib, JAK1, JAK2 inhibitor, anti-inflammatory type drug. We've got some real experts here at Cedars like Stan Jordan, we're lucky to have, who's also doing an anti-inflammatory IL-6 inhibitor study. But the Act 2 study is half enrolled. We'll find out soon if we have a signal with baricitinib. So should we be using an antiviral drug and an anti-inflammatory? Seems to make a lot of sense. I think like Jonathan said, there's no silver bullet. And then finally, we're already designing Act 3. We're having conference calls twice a week. Our next one is 6 a.m. on Saturday because it's a worldwide call. And we're going to work on, as soon as we get the early results from Act 2, we're going to blast into Act 3 and have a third study, again, a large study, hopefully incorporating the results from Act 2 and deciding where to go next. Do we use an anticoagulant next? Do we use a drug like EIDD 2108? Do we an anticoagulant, or should it be a monoclonal antibody? And there's other studies being designed too. And I think the stuff that Peter's doing with monoclonal antibodies is really fascinating. So we're covering all bases here at Cedars. It's very exciting. The teamwork between infectious disease, critical care, our hospitalist medicine, the nurses, research coordinators has been very satisfying, exciting work.
You raised one of the points we haven't hit on directly, but the unique cytokine storm that we see with these patients, the very high interleukin-6 levels, ferritin levels. It's not something that we've traditionally looked at in ARDS patients, and which has led to a number of different anti-inflammatory approaches, including what is leaking out with dexamethasone and maybe solumedrol. But I think we need to see those data. I think one of the things we have learned over these 4 months is that some trials have gotten into the press very quickly, and some of them have been retracted. So I think we need to be very careful in analyzing data before we make subsequent decisions in terms of clinical care.
And one very quick comment, Paul, if I could, on the dexamethasone study, recovery study. Big study, seemed exciting. I think we have to be very cautious about a study, and I believe steroids may work if they're done correctly, but we don't know yet. This was not a double-blind study. The mortality in this study was more than twice what we see here at Cedars. I think we have to be really careful. There were multiple randomizations, not double-blinded, potential for selection bias, ascertainment bias. So it's exciting, but I think we need more steroid data before we jump in here.
I think that's right. I think, our mortality rate at Cedars for intubated patients during the first phase of this, where the data are, of course, evolving, was less than 20%. And that's largely with supportive care because the initial medications that we were using probably didn't work aside from remdesivir. But I do think you're exactly right, the importance of the supportive care. And as Dr. Chen mentioned, the prone ventilation, it's enormously labor intensive to do that. And if you're overwhelmed with patients, it's going to be very difficult to do that. So I don't think that we can place enough emphasis on the quality of the supportive care. And we've been fortunate here at Cedars to really have some of the best outcomes. Well, I think we're sort of getting close to the end of our time. I think some of the other things we wanted to talk about, and maybe I could ask Dr. Chen and Dr. Tapson to comment. As we are evolving with this, as we're seeing patients who are chronically ventilated, some have to move on to rehab places, but what do we think the lungs are going to look like in these patients that survive when we look 6 months down the line? I would be curious to see where you guys think this might evolve.
Yeah, that's a good question. I mean, we won't know until we get there. If you want to take the other ARDS data that's out there, in general, if you wait for up to 5 years, if you look on a lung function standpoint, they all tend to look normal. You might find on the CT scans some scarring, some bronchiectasis, but for the most part, the lung functions will normalize. And, we have a lot of redundancy in the lungs. And so, the hope is that these patients that have ARDS from COVID will have normal respiratory status, and what we know from other ARDS studies is that they will have a lot of neurocognitive and musculoskeletal type issues long-term and not necessarily respiratory issues.
And
I'm glad you mentioned the neurocognitive. We didn't really touch on the delirium, which has been remarkable in these patients. We sort of in quotations call it COVID brain as patients evolve during their illness. Maybe you could comment a little bit on the sedation and the challenges we faced with getting folks to wake up.
Right. So, we had to sedate these patients a little heavier than usual. And a lot of it is because of their delirium. We were finding they were pulling out lines, pulling out ET tubes. And that was very dangerous because we can't easily go into the room. We had to get gowned up first. And so, unfortunately, we just had to sedate them a little bit heavier than usual. Plus, when you start paralyzing them or doing prone ventilation, we also have to sedate heavier. And so that may contribute to, what we've called the COVID brain, but it's hard to, we also wonder if the coronavirus, the SARS-CoV-2 is actually doing something upstairs that is actually contributing to this also. And it's just taken a long time to get patients off the ventilator. And sometimes we would have their respiratory failure recovered, and it would take another week or two, if not longer, to get them off the ventilator.
Right. And I was wondering, Vic, if you could comment. We talked about the coagulopathy, but we didn't really say much about how we're treating it. Could you give us sort of your perspective on that?
Sure, Paul. A couple very quick points is everyone needs DVT prophylaxis, there's no doubt. We tend to go with once a day low molecular weight heparin just because it's easier for nursing and for exposure. But for sicker patients, we fairly rapidly graduate to low molecular weight heparin at prophylactic doses, but twice a day, so double dose. There's a lot of controversy. We have scathing arguments about whether to put patients on therapeutic anticoagulation. And we don't have the data yet. There's at least 5 big trials, Canadian trial, 3,000 patients, a trial we may be involved with here, looking at higher dose anticoagulation and randomizing these patients. Another important point, I think, is that maybe we should be prophylactic these patients when they go home. We've got very good data from the Magellan trial we published several years ago in non-COVID patients with post-hospitalization DVT prophylaxis in the acutely ill medical patient. And these COVID patients certainly apply. We don't have data yet, but looking at a DOAC such as Patrixaban or Rivaroxaban for 30 days, we're already starting to do this. It's part of our protocol. I think it's really important in these disabled patients to consider post-discharge prophylaxis.
We do have a question in patients on immunosuppressants for lung disease. Do we recommend suspending treatment? We have taken care of a few patients who've had organ transplants, kidney transplant, lung transplant. But in general, we haven't completely suspended immunosuppressive therapy. Dr. Chen, do you have anything to add to that?
You're absolutely right. We continue really everything they're taking, and if anything, we're augmenting their immunosuppression with some of the things that we're giving them. With the anti-IL-6 inhibitors, and now people are starting to look at dexamethasone. So, we do not stop immunosuppression, particularly in transplant patients, which still need to have that.
Well, I think we're getting near to the top of the hour, and I think one of the things we've all come to realize is COVID is not going away. We continue to have a stable cohort of patients on ventilators and in our ICU. And of course, we see around the country that there are spikes in cases in a number of areas, including Los Angeles County. So this is here to stay. We're going to be continuing to evolve our treatment. It's amazing how much we've learned. I'm very proud of our group here at Cedas Sinai because I do think we've had some of the best outcomes in the country because we're fortunate to be, at a great hospital and have great people to work with.